guy, his MD, also at the University of Calgary, completed his residency at UBC, and then fellowships at MD Anderson and at the NIH. His research explores the underpinnings of high-grade glioma, genetics and epigenetic events that contribute to the development of these tumors. And he's going to be discussing malignant brain tumors with us today.
Thank you. Okay, am I projecting correctly? Okay, so these are my disclosures. I have research agreement with Synaptive, which I'll touch upon a little bit in the last part of the talk, but it's just a research collaboration unfunded. So today we're going to discuss currently available predictive tools that are available to neurosurgeons who operate on gliomas. We're going to take a little bit of a deeper dive into some of our own outcomes in our data set here, spanning 2013 to 2020. We'll look at some of the shortcomings of the current models and how we might be able to improve our predictions in counseling patients about their outcomes, and then also how this can impact and improve patient selection on the part of neurosurgeons for selecting patients for surgery. Okay, so I'll just start with a few brief vignettes here just to keep in mind as we go through this talk. Example one, here's a 45-year-old gentleman, headaches, short-term memory deficits, otherwise intact with this tumor appearing to be a high-grade glioma. I think many surgeons would agree that this patient would be a good candidate for resection and is likely to have a pretty good outcome compared to patient two here, 75-year-old woman with progressive right hemiparesis and this sort of smaller sized tumor located deep in the region of the thalamus and descending cortical spinal tract. So I think also there would be fair agreement here among neurosurgeons that something like this should probably just be biopsied and the patient be put into adjuvant treatment pretty quickly. And then this case, 39-year-old gentleman with mixed dysphasia and right hemiparesis, very large tumor on the dominant side. And despite the volume is infiltrating into many eloquent and deep areas. So I think something like this, there would be mixed input from a panel of glioma surgeons, what should be done, how much can be done, whether to biopsy, which part to try to remove. So keeping these vignettes in mind, we're just going to look here at some of the established prognostic factors that are known to help inform surgeons whether they should or should not operate on any given patient. So these can be categorized generally as preoperative as well as postoperative. And for surgeons, we're more interested in the preoperative factors. So what do we know about this patient before any intervention is done that can help guide us in our decision making? And these may be clinical factors as well as radiographic factors. In terms of high-grade gliomas, the ones that are commonly cited are age as a clinical factor, KPS at presentation, neurological deficits, as well as whether the tumor crosses the midline or does infiltrate into the deeper structures. Certainly, extent of resection is an established factor, but this is not really a preoperative factor at all. It's more of a postoperative factor, so we don't really know those ahead of time. We also, in this category, would be the molecular features of the tumor, which we don't have a good way of predicting ahead of time, as well as treatments that are known to improve outcomes that may be given. So including temozolomide and radiation therapy is the main two. And this is similar for low-grade gliomas, where age, seizures, deficits, whether the lesion crosses midline, and also the size of the tumor at presentation are the main preoperative factors, with many of the same postoperative prognostic factors. So we put all these variables together using statistical models to try to anticipate and predict what the outcome, meaning both the overall survival and progression-free survival will be. And by and large, a lot of the literature is focused on more traditional statistical models, the Cox regression model as the most common one that's done in the literature. And then more recently, using higher dimensional data sets involving molecular data and radiographic data, radiogenomics, machine learning algorithms have also been explored. I'm going to just talk briefly here now about 3 current models that are available, have been published, are probably the largest models, and do provide something in way of a tool for surgeons at present. So this first one, the RTOG Nomogram, is based on training set of data from 800 patients that were involved in 2 negative clinical trials. These were a typical sort of cohort of clinical trial patients with demographic factors that sort of reflect that. So fairly good KPS, a bit on the younger side in terms of age, and patients who had a fairly good rate of gross total resection as well. And then this Nomogram was validated subsequently on another negative trial of 555 patients. And what they found in this trial or for this Nomogram are listed here, showing that as expected, we have age, gender, KPS, as prognostic factors. Down here at the bottom, these are postoperative factors that were included and found to be significant. So subtotal versus total resection, as well as MGMT status. And in terms of using something like this, for a neurosurgeon, this is based on a Cox proportional hazards model. So it's sort of additive in terms of the risk factors or the prognostic factors. So this just shows how something like this is used. You go along the top line here for age, for example, a 65-year-old would translate to about 70 points. Second line, gender, male versus female, male, a little bit of a higher risk, and that translates into about 15 points. And you go down the list of your various factors, and then you add up all the factors here. And then this dotted line here shows exactly what the Nomogram predicts as the probability of survival at 6, 12, and 24 months. The second model that I just want to touch on is the surveillance and epidemiology and results database model. So this is a very large cohort of almost 17,000 patients diagnosed over 10 years and focuses a bit more on demographic characteristics that would be more easily collected, on such a large cohort of patients. So again, age, there was no performance status data. There was some information on whether the patient had a gross total resection versus biopsy or subtotal resection, and then some information as well about tumor characteristics. And then also what treatment was ultimately received, which by and large, most patients had radiation and temozolomide in this cohort. So one interesting thing that I found, in terms of how they developed this model was they did not actually, or they compared the traditional Cox regression model to a different type of probability model, the accelerated failure time model, and found that this type of model actually improved slightly the performance of the model as evaluated by this factor called the C index, which essentially takes 2 random patients out of your cohort and looks at whether the model predicts whether patient A versus patient B does better, and then looks at the actual result. And it's a C index in terms of concordance index of whether that random sampling matches up to the actual result. And you're aiming for a C index about 50%, 50% being flip of a coin. And they found that the AFT model slightly outperformed the Cox model in predicting outcomes. And another way of looking at this is also the difference between the Cox and the AFT models. The Cox model tries to predict the yellow arrow here. So how much of there is a risk, compared to the baseline of any given patient being alive at a certain point in time. So you could say that, patient A has, double the risk, double the hazard ratio compared to patient B based on differences in the prognostic factors. Whereas the accelerated failure time attempts to model the actual difference in survival time. And so different statistical assumptions have to be made, but and the accelerated failure time model is maybe a little bit less flexible in terms of the type of data that it can be well suited for. But for the purposes of neurosurgeons looking at patients and glioma outcomes, accelerated failure time models actually make a lot of sense and produce a lot of information that may be found to be more useful in counseling patients. So again, hazard models answer the question of how much does removing X percentage of this tumor improve the chances of survival at Y amount of time, say 1 year. Whereas the accelerated failure time model will be able to answer the question, how much additional survival time does removing X percentage of tumor give this patient versus, for example, 0% of tumor removal or biopsy, and then going into chemo-RT alone. And so the final model for the SEER database GBM model had these variables, and actually present an online calculator that can be used to, by clinicians to input the various important factors and to produce, the estimated survival times. You can then compare, for example, gross total resection versus biopsy to get sort of an estimation of the potential time gained by an approach that would contain a gross total resection versus, say, just biopsying the patient. And then the third model I'm just going to touch upon is the MD Anderson accelerated failure time model. So this is a 721 cohort, patient cohort with, again, fairly good performance status overall and a bit of a younger age compared to the average for all high-grade glioma patients. And then they've had a validation cohort of about 100 patients. So again, this was an accelerated failure time model looking at these variables. The distinguishing characteristic here is that they did a very quantitative analysis of extent of resection to be put into the model compared to, say, the SEER GBM model, which only looked at gross total resection versus subtotal versus biopsy, whatever those mean in terms of percentages. Here, they actually did volumetric analysis, which when factored in to this model actually can give you a much more exact estimation for survival time. And can produce these sort of charts where you're seeing, with greater extent of resection, this is sort of the expected gain of the patient on the left, which is age 40, KPS 100, versus, say, a patient who's 84 and KPS 60. Notice that the differences in the y-axis here, you're having much less potential gain, only 55 days in the case of the patient on the right, with a subtotal versus gross total resection. And again, the same sort of concept can be applied in terms of determining how much adjuvant therapy adds to a patient's treatment in terms of survival. So here they have different curves for surgery alone versus radiation alone, Temodar alone, and combination therapy. And you can contrast and then compare, what a high performance patient would gain versus a patient that's lower performing. So they had a very good result in terms of how much predictive error their model produced, only in the range of 4 to 5 months, which is considered very good. And they made the argument that this quantitative valuation of extent of resection into the model outperformed a model where you're just saying gross total resection versus subtotal resection. The limitation here being, though, that predictions are really only as good as what the estimate is of the extent of resection, which we don't know ahead of time. And so when you do this in a post hoc way, yes, you can do a volumetric analysis and get your extent of resection. But when you're seeing this patient in front of you, it's really a guess. And also, a model like this also gives no clear guidance on weighing benefits versus potential risks. And so, we noticed on those curves that there's sort of this continuous increase from 0 to 100% resection, whereas we know as surgeons that, if you're going to do a 10% resection on a patient who has poor performance status, you're actually probably delaying treatment that does work, like radiation treatment and temozolomide, and you're not going to actually get any meaningful survival gain from that, and putting the patient at risk for surgical complications that could further delay treatment. So in thinking about this sort of a little differently, we might imagine this concept where this black line here representing the survival gain from removing a tumor, say 50% to 100%, you get an increase in that gain, but you have to cross this kind of red line threshold where there is the risk of the general anesthesia, general surgical complications, the risk of neurological decline following surgery. And you need to kind of stay in this kind of blue zone where benefit exceeds risk in order to obtain sort of the desired amount of months of survival gain here on the y-axis. This may be a much lower benefit risk ratio in a patient that is, say, for example, high grade, but lower performing and may have a higher medical comorbidity, which produces more risk for surgery. And then we also have to think about the case where the tumor goes into a region of the brain where if you do end up in that area, you may produce a deficit, which can increase the risk to the patient and decrease the amount of the window here of therapeutic effect. And so in this case, for example, a patient, a tumor that's say 10 or 15% of its volume is in the motor region, you don't want to go that far because you may actually lose all of the benefit of the surgery. And then there may be cases where there really is no clear benefit because, the volume of the tumor is really in an unresectable region. And there really is no situation where we're going after the tumor makes any sense in terms of giving the patient meaningful survival, and the patient should just get a biopsy and go to radiation. And so we can just look at all the different scenarios here, whether the patient has good performance versus poor performance, and how close or deep the tumors going into those critical or eloquent areas of the brain. And we can identify here, scenarios, say the eloquent tumor in a good prognosis patient, but a lot of the tumor is eloquent, where there may be a question as to, whether we should operate. And for example, say the poor performing patient where, you're approaching an eloquent area, but maybe not quite in it, but, you are expecting that if you get too close, you're going to be, causing a deficit that may recover, but it may take 3 months or 6 months and may slow down getting radiation and temozolomide. So assessing, resectability has been a challenge overall. The factors that we think about as surgeons are the eloquence of the tumor, whether it involves deep or midline structures in the brain, and also the focality, whether it's multifocal, whether it involves both hemispheres of the brain. Eloquence has really been traditionally thought of as motor and speech cortex, and many older studies have just have just assessed this as yes, no. Same thing with involvement of deep structures and the focality or bilaterality of the tumor. Things that are not traditionally looked at or accounted for in terms of eloquence are visual tracts. It's sort of variably accounted for in studies, and also the deeper tracks, that connect motor regions to the spinal cord, as well as the regions that connect, the tracts that connect the speech areas. Involvement of deep and midline structures, insular tumors have posed a challenge in terms of how to exactly to assess this as a resectable lesion or not. And there are considerations such as the vascularity of perforators going on the deep aspect of the tumor that need to be considered and aren't traditionally accounted for in the literature. And then, focality and bilaterality, many studies don't really consider, the surgical corridors that are chosen by surgeons and what can actually feasibly be reached, from the chosen corridor. There have been some scales that have been developed to assess resectability, putting some of these factors together, one of them being the NIH Recurrent GBM Scale. There have been approaches such as crowdsourcing even that have been looked at. And I think all this really shows is that many surgeons here, 1 through 13 different surgeons, assess the resectability of the same tumor in many different ways. And so there's a wide range here of aggressiveness, as the authors here have put it, in terms of whether a surgeon will go after any given tumor. And then a little bit more of a quantitative method that's been proposed is sort of a probability map, basically looking at pre and postoperative images of tumors and overlaying all of the resected portions of tumors onto the brain to sort of show where surgeons in a post hoc sort of manner went in terms of going after a particular tumor and where they avoided going after the tumor. So I'm going to now just get into some of our data and try to integrate this with what we know here about prognostic factors. So this cohort of ours here at Mount Sinai between 2013 and 2020 are patients who underwent any surgery, so biopsy all the way to full resection. And were categorized according to the current classification scheme, high grade being anything grade 3 or grade 4 in the diffuse infiltrative glioma category. We had about 150 patients in this cohort, 64 or 44% female. This was the breakdown of the pathologies. By and large, glioblastoma was most common. Our age distribution, compared to some of those published cohorts, is probably more in keeping with the epidemiological, occurrence of GBM. So it's about 63, 64 years old. And then for the other high-grade gliomas, non-glioblastomas, this was younger. KPS also were about 96% above or at 70, and this was similar in the other high-grade gliomas. They were about equally distributed between left and right. 10 to 12% here were bilateral, and then a small percentage were primarily situated in the brainstem. The rate for eloquence is also in keeping with many other reported cohorts at a bit above 50%, 50% extending into the basal ganglia, thalamus or brainstem, and then about almost a quarter were recurrent tumors. And this is also in keeping with cited statistics saying that about a quarter of patients with recurrent glioblastoma are offered repeat surgery. In terms of the size, based on a volumetric analysis of the preoperative tumor images, our median and mean volumes are between 30 and 40 cc's. And then extent of resection, median about 98%. And for the other high-grade gliomas, median extent of resection was about 90%. Overall complication rate, around 12%, including general post-surgical infections. About 20% of the cohort experienced a drop, at least transiently, of 10 points or more, and also about a quarter experienced immediately after surgery new or increased motor deficit. And I think this goes along with, the half or so of patients who had tumors that were directly involving eloquent regions. So overall survival, we're still working on getting good, vital statistic data on everyone in our cohort. So this has to be taken with a grain of salt, but we, are seeing here with, quite a lot of censored data that, we're looking at, beyond 20 months for grade 4s, which, certainly does exceed, what's cited in the literature. And then for the grade 3s in the cohort, we don't reach the median out to beyond, 3 years from the time of surgery. We had better data, more reliable data, I would say, for progression-free survival. And so that's where we kind of focus more of our analysis of the cohort for GBM here and for the diffuse midline gliomas, about 5 months of progression-free survival, which is less than what we expect from some of the cited literature that says that this should be around 7 months. But we include here reoperated patients. So for newly diagnosed patients, we're at sort of the literature cited range of around 7 to 8 months. And then for the reoperations, that's where we see that we do a lot worse with the amount of time it takes for these tumors to show any sign of further progression. So, we cite these two papers a lot in the glioma literature in terms of what is the most meaningful minimum threshold for the extent of resection in order to produce something that's meaningful to the patient in terms of survival gain. And so this paper from MD Anderson here on the left basically divides their cohort into two groups. Group A is X percentage of resection, and Group B is those that did not achieve that amount of resection. And then you compare the survival of those two groups, doing multiple comparisons for every extent of resection, and identify the point of percentage here where there's the greatest difference in that survival between those two groups. And doing that sort of technique, they found this threshold to be around 90%. More recently out of UCSF, they have this paper here using a very similar technique, identifying that it was around 80%, somewhere between the 60 and 80% range of extent of resection to produce the largest difference in survival. So doing this on our own cohort, we see the green line here, which is the survival of that group A, above, say, 100% resection would be up here, compared to all those where we did not achieve 100% resection of the contrast enhancing tumor. And we repeat that for all of the percentages going from right here to left, going down. And then the blue dotted line shows us the hazard ratio between Group A and Group B. So we're looking for this line being above 100, meaning that the red line has a higher risk of failure to survive, whether it's progression freedom or overall survival compared to Group A. And we notice here that difference spikes somewhere here in the 60 to 70% range. The yellow line here is just the p-value for that. So the p-value being is transformed here. So above 50 means that it's less than 0.05. So this is a significant result in the 60 to 70% range. We can repeat this for the entire cohort of grade 4 gliomas that we have, and find that it's a very similar result, with that extent of resection threshold being somewhere in the 65% range. We can kind of flip the question around and also ask, how much residual tumor volume is needed to what's the minimum needed, or sorry, the maximum needed in order to get a meaningful survival difference. And this also matches up with what's been reported, that if you have under, around 1 to 2 cc's of tumor left, that's kind of where you will see the biggest difference in the hazard ratio. And the same thing held for all grade 4 gliomas. We're looking at around about, somewhere in the 1 to 3 cc range of tumor residual. Age didn't show any clear trend. And KPS also, as expected, showed that there was an increase in the hazard rate, at 70 KPS. And this held through for the whole cohort as well. Okay, so looking at say the SEER model as applied to our data, we see that it doesn't really perform that well in terms of predicting our overall survival patients where that data was known for our cohort, with a mean error now of almost 8 months. And a relatively weak correlation, as shown by a low R and p-value that was not quite significant. Looking at applying some of the statistical models now to our own data, starting with the Cox Regression model. Here we found that comparing these two models, the one on the left without extent of resection, to the right, which includes the extent of resection, and that one is I chose to compare these because we don't really know extent of resection beforehand. So the left is really the pure preoperative model. Does reasonably well, the Cox regression model in producing the predictions of the PFS. But this is improved by adding in extent of resection data. So this basically shows us that it is important to account for this as much as possible when we're counseling our patients. And then this we added in the rest of the postoperative variables, such as residual tumor volume, actual histology, whether they got temozolomide and radiation, and found that there wasn't really much further improvement by adding those additional postoperative models, variables. Looking at the AFT, so here we found that, yes, AFP does tend to outperform the Cox model in terms of the C index. The Cox model being around 0.72, here we're looking at 0.74 or higher. And again, adding in extent of resection does slightly increase that C index. Again, pointing to the importance of this factor in predicting outcomes accurately. So how do we actually use EOR in a preoperative setting? Well, this really, when you think about it, is very similar to the concept of resectability, where resectability really is expected to be the maximum EOR possible for any given patient. And so although resectability will be predicted to be in general higher than the actual extent of resection achieved, this should be correlated in a pretty predictable way. So this is where we're now trying to develop a method based on whole brain tractography to assess resectability more volumetrically. And so I give this example here of this 36-year-old patient of mine diagnosed with an anaplastic oligodendroglioma in the left frontal lobe. And using tractography data are able to, first of all, volumetrically assess this tumor, segment it, and then overlay it with the tracts. So the tract information actually will give us both the location of the eloquent cortex based on where the tracts are connecting into the cortex and the tract within the white matter itself. And so we can do an actual overlap calculation between the volume of the tumor and whichever tract or tracts we're interested in this case, arcuate fasciculus as well as the corticospinal tract, and calculate this overlap volume, which when subtracted from the entire tumor volume gives a volumetric assessment of resectability, potentially, as we're still validating this. But the idea here is that we sum all of the tumor overlap volumes between all of the tracts that we're interested in, as well as deeper structures, including the thalamus, basal ganglia, and the brainstem. And then for bilateral and multifocal tumors, we will consider the overlap volumes only in the hemisphere or the lobe where the largest tumor burden is located in order to calculate this theoretical maximum resectability for the patient. And so, again, this is a way to preoperatively estimate in a volumetric, quantitative, and continuous manner a maximum extent of resection achievable. And this is expected to be correlated with the actual extent of resection that we will achieve postoperatively. The idea here is that we substitute this variable of the resectability for percentage EOR, which we know is important for these models, and compare, how that changes the model fit. And so this would be, if it's validated, an objective method of comparing tumor characteristics, i.e. the eloquence of a tumor between different cohorts of patients. This is not really possible in an unbiased manner at present, as we don't have very good tools for this, but with a quantitative assessment of resectability, we may be able to achieve this. This also has a potential of providing surgeon-specific quality assessments and assurance for individual patients. So we can look at questions such as whether a difference between the anticipated calculated maximum extent of resection resectable for a patient and the observed actual extent of resection, whether a difference between these two values actually predicts any type of difference in terms of patient outcome. And then, of course, our model currently is not complete. And as seen in the SEER database, there are other factors that we haven't looked closely at yet that may factor into this, including race, ethnicity, marital status of the patient, and insurance status, all of which were found to have some importance in the SEER database model. Of course, the SEER database model also did not incorporate KPS and neurological deficits at presentation. And so, some of those variables not included in SEER could be more powerful in terms of prediction than some of these factors here. But I think we have to look at all of the factors together in order to really determine this. Okay, so going back to our model for surgical decision-making, we have this curve where we know the height of this red threshold, which is probably linked to the patient's performance status and medical comorbidities. We have the position here of the black curve from left to right, as well as the height of the curve, which will relate to how aggressive the tumor is, which will determine how much of it you need to really remove in order to get a meaningful result in terms of slowing down the tumor's recurrence. And then this uptick in the red curve relates to where we start to get into deep or eloquent structures where the risk or the hazard will increase. And so now we have a more getting towards a more quantitative measure of where this will start to increase for any given patient. Now, the height of this curve is the last question. So how steeply does this go up? How much is there a potential for loss in terms of survival gain based on how much injury or how severe a deficit a patient develops following surgery? And for this last question, we can go to first of all the literature, which in this paper pointed to the fact that patients who had new postoperative motor or language deficits tended to have less overall survival by about 3 to 4 months compared to those who had no deficit following surgery. Looking at our own data, comparing first of all, patients in the red here who had no deficit versus those who did acquire at least immediately after surgery a new motor deficit, we do see a difference here. In that that same 4 to 5 month range, keeping in mind that this is actually progression-free survival rather than overall survival. However, we did note that this blue group did have a higher proportion of eloquent, higher grade, and lower performing patients. So when we did a subgroup analysis here, that was kind of interesting, looking at eloquent versus non-eloquent tumors, we found that those patients that had eloquent tumors, this new deficit didn't really turn out to have much of an impact on PFS at all. And the thinking here is that many of these patients will have transient deficits that do recover with rehab and don't then materially impact their candidacy for further treatment. Whereas the non-eloquent tumors, where we had patients that developed a new motor deficit sort of unexpectedly, so a lot of this was maybe perhaps vascular injury, the patient had a stroke, then that's where we see the difference of that 4 to 5 months originate from. So this is kind of an interesting insight from our own data, showing that it's not really just, one size fits all. You have a deficit, that means that you're going to do worse in terms of progression freedom, overall survival. It's really the context, whether and the type of deficit, and also with etiology. That may be important, for example, vascular versus getting close to a tract or an eloquent region of cortex. So just coming back to our vignettes at the very beginning and trying to apply our AFT model to see what that actually tells us so far about outcome. The 45-year-old man with this large non-dominant temporal lobe tumor, we plug in all of these variables into our calculator that we have from our AFT model. And in the green here, we can plug in the values for a maximal resection. And our prediction is about, just short of a year of progression-free survival, compared to a biopsy alone, where we plug in 0 for our extended resection. And we see that subtracting to these 2 time values, we have a survival gain approximating here 3 to 4 months. And we can consider, on the flip side, the risk of acquiring a motor deficit in this context, which, being a non-eloquent tumor, if he does develop, say, a choroidal infarct from this surgery, he will probably lose around 4 months of progression-free survival. But the risk of that, in any surgeon's hands may not be that high. We can make a more informed decision about whether this patient should have the surgery or not. Same thing will apply to this 75-year-old woman with a much smaller tumor, only about 6 cc volume that we measured. And given the smaller size of this, resection, if possible, can produce up to a 3.5 month progression-free survival gain. However, this being embedded in the thalamus and probably already infiltrating into the corticospinal tract, high likelihood of acquiring a motor deficit due to a tract injury. And so we will probably lose all of that gain if we were to go after this tumor and rather than biopsy it. And finally, the 39-year-old man with mixed dysphasia and this very large heterogeneous tumor, our model shows that with something this large, 120 cc's of tumor volume, the model showed us that actually any amount of resection in this is not likely to give very much in terms of PFS gain. It's a little bit surprising. We're still, I think, needing to look at this model with the tractography volumetric calculations in order to fine tune it. But it's not outside of the realm of reason that, something this large, in almost all scenarios, you're going to do better with just trying to get this patient into adjuvant therapies if you don't need, much tissue, to make the tissue diagnosis. And then this just summarizes, the performance of our model so far. Error is not bad, but not that great, in terms of some of the other models that have been published out there. And I think this will improve as we work towards, getting more data about resectability. And to summarize, our accelerated failure time model does appear to outperform the Cox model in predicting our outcomes after high-grade glioma surgery. And this is just based on our preoperative clinical and radiographic variables. These models may benefit from more objective methods of assessing tumor resectability in the preoperative stage using tractography and AFT modeling combined with data-driven patient-specific risk assessment is likely to generate the most useful tools for surgeons in actually selecting patients and counseling them prior to surgery. Just like to acknowledge our team of medical students here, William, Haley, and Tish, who have worked very diligently to collect a lot of this data. Technical support from Evelyn from Synaptive, and then Xinyan, who's helped a lot in doing the math here for the models. Thank you very much.
Thank you, Ray. That was really fascinating talk, and I love how deeply you have gone into your own data as well as the literature. Do you take into account the impact of subcortical monitoring in getting those maximal resections? So it looked like most of what you focused on were preoperative evaluations.
Yeah, I mean, that's been the main focus, the preoperative evaluation of whether the tumor invades any specific tract. Yeah, it would be nice to for every tumor validate that based on what the tractography is telling us ahead of time versus what we actually find with stimulation during the OR, and certainly that would impact actually what actual extent of resection we actually achieve. So I think this is all very interesting to look at, where we have the preoperative prediction, and then we can then go and look at our entire series of what we actually achieved in these patients, and then kind of dig into what findings we may have had during the stimulation that may have impacted that.
Yeah, that's a paper right there, isn't it?
Yeah.
Wonderful. I'm sure there are comments, Raj.
Yeah, Ray, fantastic talk. I have a question just to get your thoughts on. There's been a plethora, as you know, of technology really accessing the tumor biology, invasion, so forth, be it through Raman spectroscopy or other modalities for determining extent of resection, but also tumor borders. How do you think that plays in? There are different companies that are even contacted, I think you and I, over the last month or so. How do you think that plays out, particularly for GBM, given that it's such a complex pathology?
Yeah, I think, always, technology to kind of push the envelope and maximizing extent of resection is great conceptually. Things such as 5-ALA, I think, does, make a difference. Other technologies where we're kind of examining borders carefully with spectroscopy or confocal, for example, I'm not sure that the impact is going to be as much, because less than 1 cc of tumor, further resected is probably not going to make an enormous difference in terms of the end outcome for any given patient. But I think a combination of all these tools and also surgeon comfort with them is what's going to increase outcomes. And so having a kind of a wider variety of tools available, I think can help things, because every surgeon is going to have their kind of methodology. in terms of approaching, resections. But it's nice to have, something that can tell us what the bar is, and then we can try to develop the tools that will try to help us, push closer to that upper bar of what the maximum, theoretical volume, resection is.
If I can just ask just a follow-up question. So you would envision that for a more invasive diffuse GBM, or like where do you think this technology offers merit or most applicability?
You mean like these probes that
Yeah.
examine the borders?
Yes.
I think for me, it's going to be more the more circumscribed looking low grades. We know that they're not really circumscribed, but they do seem to have that T2 flare margin, and I think that the utility of some of these probes could be in just in real time checking those margins. These tumors are often fairly invisible on ultrasound. We can assess them using intraoperative MRI, but where we don't have that, and we don't also have the real time ability to just probe a certain area that we have a question about and check whether we missed some low grade there. It's hard though, right? I think a big challenge in the field right now to actually have enough discriminatory power in some of these technologies. So Raman spectroscopy as well as confocal. We had discussion about this with the neuropathology group, but looking at the images they actually get from these confocal microscopes, you really can't tell a margin. They're not good enough right now to tell a margin. And even with fluorescein, they can't really tell it. So I think there has to be some more development in that arena.
Thank you.
Ray, since the biggest predictor of a poor outcome relative to what you expected is the new deficit in a new unexpected deficit, can you go back and look at those new unexpected deficit patients and come up with an algorithm to predict that better? Obviously, they're unexpected for a reason, but maybe there are features in this cohort that can help you predict that it could occur.
Yeah, I think that's definitely worth looking into. We need more patients like that. Fortunately or unfortunately, there's not that many in our cohort so far, but from my recollection, a lot of them, are sort of like perforator injuries, in deeper tumors that are non-dominant, but maybe it's a perforator that's supplying a tract that's going by.
Yeah, interesting. Well, this is a wonderful talk. It's much more than a talk. It's it's a body of work, and you should really feel great about this. Wonderful that you presented it. I think we should probably get ready to move on because it's reached that 9 o'clock hour.
Yeah, thanks everybody.
Thanks, everyone.